All right, welcome back everyone to another High Yield Explainer. Today we're cracking open the board examiner's playbook on a topic that is literally guaranteed to show up on your exams: chlamydial infections. If you want to maximize your score, you absolutely cannot afford to mix up your serovars, your life cycles, or your treatment durations. So we're going to do a rapid-fire, highly structured review of exactly what you need to know. We're stripping away the fluff and focusing strictly on the clinical and exam high yields. Okay, let's dive right into this. Here's your ultimate categorical mental map. We're going to start with the chlamydial life cycle, march through the serovars alphabetically, that's trachoma, oculogenital, and LGV, cover the respiratory species, and then round it the whole thing out with high-yield exam warnings. Let's get to it.
First up, Section 1, the chlamydial life cycle, or as I like to call it, the biological disguise.
So chlamydia are notoriously sneaky, right? They're obligate intracellular bacteria, they lack peptidoglycan, though they do have a cell wall structure, and they are technically gram-negative, but they're simply too small to see on a standard gram stain. You absolutely must memorize the difference between their two unique forms. The elementary body, or EB, is the infectious form. It's heavily adapted for extracellular survival, so it can easily spread from host to host, but, and this is key, it does not replicate. On the flip side, you have the reticulate body, or RB. This is the metabolically active form. It lives inside the host cell, replicating away by binary fission, but it is not infectious. To keep it straight, just think E for enters and R for replicates.
The timeline basically goes like this. First, that infectious elementary body enters the cell. Second, it unpacks itself and reorganizes into the reticulate body. Third, the RB multiplies rapidly by binary fission. Fourth, once it's built up a massive army, those RBs reorganize back into EBs. And finally, step 5, the host cell releases these shiny new infectious EBs. Lock this into your brain. This entire incubation process takes exactly 48 to 72 hours.
Moving right along to Section 2, serovars A through C, responsible for trachoma. We're starting at the top of the alphabet and focusing straight on the I.
Now, what's really staggering here is the sheer scale and severity of this disease. Trachoma is actually the leading infectious cause of preventable blindness globally. It's hyperendemic in parts of Africa, the Middle East, and Southeast Asia, and it's transmitted by direct contact or, incredibly, even by flies. In these hyperendemic areas, the prevalence reaches practically 100% by age 2 or 3. The clinical progression you need to track for your exams starts with follicular conjunctivitis, which then leads to a pannus, followed by trichiasis, which is where the eyelashes literally invert and scrape the eye, ultimately resulting in devastating corneal scarring.
For treatment, you've got two primary options. You can use a massive single dose of oral azithromycin, 1 gram, which is fantastic for mass drug administration programs. Or, alternatively, you can use topical tetracycline 1% eye ointment. But notice that duration. It must be used for 6 entire weeks. Keep this treatment modality in the back of your mind because as we move to the next serovars, the rules are going to change completely.
All right, Section 3, serovars D through K, the oculogenital infections. This is the most common bacterial sexually transmitted infection worldwide. And honestly, its defining feature is its stealth. Listen to this, 80 to 90% of women and over 50% of men are completely asymptomatic, but that subclinical infection can lead to pelvic inflammatory disease and subsequent tubal scarring. And speaking of pelvic inflammatory disease, you absolutely have to know this eponym, Fitzhugh-Curtis syndrome. This is perihepatitis. If you see a question stem describing a young, sexually active woman presenting with right upper quadrant pain, tenderness, and laparoscopy reveals violin string adhesions on her liver capsule, you immediately think of Fitzhugh-Curtis. And remember, while it can definitely be caused by gonorrhea, it's actually more strongly associated with chlamydia trachomatis. That contrast right there is a classic trap. 7. Literally burn this number into your retinas. When you're treating an uncomplicated genital infection caused by serovars D through K, the exact treatment duration for doxycycline is 7 days. 1 single week.
Now, let's look at the classic neonatal traps for serovars D through K. If a mother is infected, the neonate is obviously at high risk. But the presentation really depends on the timeline. Neonatal conjunctivitis typically presents between days 5 and 19 of life. Contrast this with neonatal pneumonia, which strikes a bit later, between 2 weeks and 4 months of age. The buzzwords you are hunting for here are an afebrile staccato cough, bilateral interstitial infiltrates on X-ray, and an elevated eosinophil count.
So the absolutely crucial point is how you treat this neonate. You must use oral erythromycin for 2 weeks.
Examiners love to trick you by asking if standard topical eye drops given at birth will prevent chlamydial conjunctivitis. They absolutely do not. Topical prophylaxis only prevents gonococcal ophthalmia. For chlamydia, systemic oral therapy is mandatory.
Let's raise the stakes. Section 4, serovars L1 through L3, causing lymphogranuloma venereum, or just LGV. This is the most invasive category we'll cover.
It usually starts off as this painless genital ulcer that patients might completely ignore, but it soon progresses to painful, fluctuant inguinal buboes. And this leads us to a highly specific clinical marker, the groove sign. This is when you have bubo enlargement both above and below the inguinal ligament, literally creating a visible groove. While it's not universally present, it's a massive exam clue. If left untreated, LGV leads to severe late-stage complications like rectal strictures, hemorrhagic proctocolitis that mimics Crohn's disease, and even elephantiasis of the genitalia, which is known as estheomene in women.
21. Boom. Just look at that number. Contrast it with the 7 we saw just a minute ago. Because LGV is so highly invasive, a mere 7 days of treatment simply won't cut it. For LGV, you must prescribe doxycycline for 21 days, 3 full weeks. Do not let the test makers catch you giving a 1-week script for L1 through L3.
Pivoting a bit, Section 5, psittaci and pneumoniae.
So we're stepping away from the genital and ocular serovars to cover this strictly respiratory species of chlamydia. Let's clearly differentiate them. Chlamydia psittaci causes psittacosis. It's a zoonosis you get from birds, specifically parrots, parakeets, and poultry. You catch it by inhaling infected bird dust. Critically, there is absolutely no person-to-person transmission with psittaci. That makes it totally unique, and it's actually classified as a Category B bioterrorism agent. On the right, Chlamydia pneumoniae is your standard community-acquired atypical pneumonia. It spreads person-to-person, mostly hitting school-aged children and young adults. Interestingly, it also has this strange, heavily tested link to atherosclerosis, though antibiotic trials for cardiac events ultimately showed no benefit.
Let's bring it all home with Section 6, high-yield exam warnings. This is where we consolidate the most frequently tested trap questions.
First warning up, sexually acquired reactive arthritis, or SARA. You probably remember the classic triad, right? Can't see, can't pee, can't climb a tree. That's conjunctivitis, urethritis, and arthritis, predominantly in the knees. It has a super strong association with the HLA-B27 gene. But the exam goldmine here is the dermatological finding, keratoderma blennerigicum. These are characteristic lesions you'll find right on the patient's palms and soles.
Okay, guys, here is your ultimate cheat sheet. This perfectly pairs the syndrome with its specific treatment duration. Uncomplicated genital DK, 7 days of doxycycline. Invasive LGV L1 through L3, 21 days of doxycycline. A neonate with conjunctivitis or pneumonia, 2 weeks of oral erythromycin. Seriously, take a mental picture and burn these timelines into your memory.
Finally, let me leave you with one last provocative question to really test your clinical instincts. A patient finishes their 7-day course of doxycycline for an uncomplicated genital infection. Can you use a nucleic acid amplification test, a NOT, as a test of cure exactly 7 days after they finish their treatment?
No way. The answer is a resounding no. You absolutely must wait a minimum of 3 weeks after treatment before repeating a NAT. Why? Well, because gnats are incredibly sensitive, and residual dead bacterial DNA will linger in the genitourinary tract, giving you a false positive and leading to totally unnecessary retreatment. Know the biology, know the timelines, and I promise you'll dominate these questions. But consider this. As global antibiotic resistance continues to evolve, will our rigid 7 to 21-day doxycycline rules even hold up in the decades to come? Definitely something to think about as you enter the wards. Thanks so much for joining me on this explainer, and good luck crushing your board exams.